Good evening, friends. Welcome you all for today's academic webinar conducted by Department of PMR, SVNIRTAR under the aegis of Association of Physical Medicine Rehabilitation of Odisha and Indian Association of Physical Medicine Rehabilitation. Friends, after eradication of polio, the next common cause of disability we come across, especially pediatric disability we come across in a clinical practice, is the cerebral palsy. So, as you all know, this is a multiple disability condition. The same child may have a learning problem, may have cognitive impairment, may have visual issues, hearing impairment, locomotor disability, and etc. It's very difficult to address all these disabilities under a single roof, especially when you are working in a government setup and you are facing challenges for addressing all these issues under a single roof. You may have to face challenges like infrastructure challenges, equipment challenges, manpower challenges. All these issues will be there. You will face this while working in a government organization, especially when you are dealing with a multiple disability. So, for these issues, how to resolve these problems, how to handle CP clinic alone or with a limited resources, we have with us today Dr. Anand Varama, who has a great experience in the field of cerebral palsy. He is currently working as associate professor in Karnataka Institute of Medical Science, Hubballi, and he has his own clinic. He is working as a consultant physiatrist, Anand Pain Relief and Rehab Institute, Hubballi. He has many awards to his credit, such as Anisha Basant Memorial Award for Best Faculty Paper Presentation in IAPMR 2021. He has also received Dr. W.G. Ramarao Travel Fellowship in 2015. He has been member of many regional and national chapters, associations such as IAPMR, IMA, IACP, ISSP, IFNR, and so on. Currently, he is in position as Honorary Secretary, Kabari Association of Rehabilitation Medicine for 2025 to 27, Joint Secretary and Web Administrator for our association IAPMR 2025 to 27, and he is also EC member of IACP. I can say is active member in Indian Association of Cerebral Palsy. I have seen him participating actively in many IACP webinars and academic events as active member and contributing his thoughts and his works in the field of cerebral palsy. So he is going to talk us regarding establishing a CP clinic in government setup, a joining of growth and learning. I request Dr. Anand Verma to share his experience with his presentation. Over to you, Dr. Anand Verma. Thank you.
Thank you, sir. Thank you. Good evening, all. At the outset, I just wish to thank Dr. Sahoo, sir, for giving me this opportunity. Today, I'll just be sharing my experience of how to manage CP cases in the government setup. And what made me to think to open a cerebral palsy clinic, a CP clinic, how it helped me in managing these cases better. As you all know, I work in a government medical college run by the state government, which is Karnataka Medical College and Research Institute. I'm a single faculty. So if you see the journey of PMR at my institute, I joined here in August 2012. It was earlier known as Karnataka Institute of Medical Sciences KIMS, and now it is known as KMCRI. So I have done my post-graduation from AIIPMR Mumbai. I worked there for some time as a senior resident. Then I worked even in Nimans as a senior resident for 6 months. Then I relocated to Hubballi, which is my birth city. See, when we are working in institutes like AIIPMR, Nimans, or any other institute which have established department of PMR, we just focus on the work. We don't have to focus on how to run the department, how to establish the department. But when you go to a new medical college where there's no department and you are expected to initiate the department, establish the department, the challenges faced are many and it's a difficult situation. So for me also the same thing happened when I got a job in this institute. Nobody was aware of what PMR is. So nobody knew what I can do, what I do, or what PMR is. When I joined the institute, the director asked me to go and report to the Department of Orthopedics, the HOD there. And then initially it was the difficult phase. I was conducting my OPD sitting in the orthopedics department for almost 2 to 3 years. But that was a consolidation phase. I got to learn many things of how to consolidate, how to make my colleagues aware of what I do and all. I started performing independent surgeries in 2014. I then, with great difficulty, I could have a separate PMR OPD somewhere in 2015-16. Again, initially, I used to sit in the PMR OPD only once a week because there are no patients in PMR OPD. And I never wanted to sit alone and do nothing. So initially, I started only once a week, then it became twice a week, then thrice a week, and then gradually it became a full-fledged PMR OPD. Even though a separate PMR department was officially established in my institute only in 2022, which is 10 years after me joining there. I started the CP clinic in collaboration with DIC in 2019. So what made me start the CP clinic? The challenges which I was facing before starting a CP clinic when I was operating and managing cerebral palsy cases, because my major practice in KMCRI was pediatric cases, and the most common pediatric cases I see are CP. One, because fragmented and unorganized care. The patients are managed across multiple departments without unified planning. That was a major hindrance. Second thing, there's no coordination. So that led to suboptimal functional outcomes. This I felt especially after the surgeries. Because that time I was operating regularly CP cases, I felt the functional outcomes can be much better if you have a coordinated setup. Then inadequate infrastructure and resources. Uh, I didn't have access to a pediatric therapy unit. There's no speech therapy, clinical psychology, social work support, etc. As we know, CP requires a multimodal management because various aspects are involved. Then also there's poor patient compliance, irregular follow-up and inconsistent therapy due to lack of organized multidisciplinary support. I've realized this, I've experienced this many of my times. The surgeries have failed because there's no regular therapy, there's no coordination, there's no regular follow-up, a consistent follow-up. So that made me think of CP clinics. So if you see the beginnings of cerebral palsy clinic, the first documented cerebral palsy, a multidisciplinary cerebral palsy clinic was started in Baltimore, USA in the year 1937. And in the year 1947, the American Academy for Cerebral Palsy and Developmental Medicine was established in USA, which led to establishment of many such CP clinics all over USA. In the UK, the CP clinics, a multidisciplinary CP clinic started somewhere in 1940s and 50s. And in Canada, the first one was established in 1970s, the Glen Rose Rehab Hospital. I had some experience of working in a CP clinic because when I was working as a senior resident in AIIPMR Mumbai, Dr. Athani there, I started a weekly special clinic for cerebral palsy. I had small experience of working there, so that was there in my mind. And also, DIC was started in KMCRI in our campus in 2016. So the CP clinic was inaugurated on 3rd of October 2019 on the occasion of National Cerebral Palsy Day by the then director and various other HODs. But I should mention this was possible only because of the full-fledged support which I have from Department of Orthopedics, Department of Pediatrics, and DIC. Without their support, without their contribution, this was just not possible. The CP clinic in KMCRI, the model which we follow, it's a regular weekly clinic held every Wednesday, ensuring continuity of care and systematic follow-up. It's a multidisciplinary team approach led by me with active participation from pediatrician, physiotherapist, speech therapist, clinical psychologist, rehab, nurse, social worker, and optometrist. So we have all the people who are essential in managing a cerebral palsy case. We do not have an in-house P&O department or workshop. So we're depending on Mahavir Artificial Limb Center and Alimco PMDK Center in the campus itself, which provide us with orthosis and various mobility aids. The Elimco PMTK Center was inaugurated in January 2025 itself. Focus on detailed functional assessments, individualized goal setting, and team-based coordination for optimal functional outcomes. So what protocol we follow is any cerebral palsy case which comes to KMCRI to our institute, whether it may come to Department of Orthopedics, Pediatrics, DIC or PMR, the first time it has to be referred to cerebral palsy clinic for detailed evaluation and goal setting. Only once assessments are complete, goal setting is complete, then for follow-up you can call him on other days. But first evaluation has to happen in cerebral palsy clinic. And I'm very happy to say that all the cerebral palsy cases which come to KMCRI, neurology, orthopedics, pediatrics, all are referred to PMR OPD or CP clinic directly by the parent departments only. Then recently, in the month of October only, we launched a monthly special clinic for parents and caregivers of cerebral palsy kids, providing group therapy, counseling, and peer support opportunities. This was launched only this month on the occasion of National Cerebral Palsy Day, which we observed on 15th of October, and we will start this clinic once in a month from next month. This is our team, CP Clinic KMCRI. It's me there with Dr. Shadab, who's a pediatrician, and all the other members of the team who play an integral role in all the successful functional outcomes. If we see the number of cases from 2019 to 2024, we see around 900 cases every year. This includes both new cases as well as follow-up cases. Now, if you see the details of the follow-up cases and new cases, we see around 25 to 30 new cases every month and around 55 to 60 follow-up cases every month. Now, the point to remember here is these are the only cases which report to cerebral palsy clinic. Because we have limitations, we cannot manage more than 35 to 40 cases in one day on a CP clinic every Wednesday. What we do is, once the evaluation is complete, once the goal setting is complete, once the patient is following up regularly with us, there is compliance, I call these patients to follow up on non-CP days, non-CP clinic days. What I mean to say is, I call all these follow-up patients on the PMR OPD days. So all the patients, all the CP patients who follow up with me in the PMR OPD, which is again a huge significant number, are not included in these statistics. Now, if you see CP clinic, by definition, yes, all cases should be of CP, but only 95% of the cases are cerebral palsy. 5% of the cases are other cases which have been referred by other departments or maybe Anganwadi workers who get these cases to CP clinic like rickets, CTV, muscular dystrophy, MMC, AGMC. Sometimes you get scoliosis, torticollis, and so on. Now, if you see the interventions done, initially this statistics include only the cerebral palsy cases which have been operated or injected with botulinum toxin from the CP clinic. This does not include the other cases which we manage surgically or otherwise. So initially for first 2 years, we didn't have access to injection botulinum toxin. So we used to do only surgeries. Then in 2021, thanks to the administrators who made available injection botulinum toxin at Institute for Management of Spasticity. Again, I wish to highlight that if you see the whole state of Karnataka, even though we have around 24 government medical colleges, there are only 2 government institutions which provide injection botulinum toxin for management of spasticity. One is our institute. The other one is Indira Gandhi Institute of Child Health in Bangalore. No other institute, government institute in Karnataka is using injection botulinum toxin for management of such cases. And if you see the statistics, the number of surgeries are decreasing or they remain fairly constant. And this is a difficult question because the senior officials here, the director, when they ask me why the number of surgeries are not increasing, it's difficult to explain them or convince them. But if you ask me, this is very positive signal. This is very positive thing that the number of surgeries is not increasing, in fact, decreasing. Because now what's happening with the cerebral palsy clinic, since the clinic is situated in DIC, we have RBSK and Anganwadi workers working with us. So the kids are being identified at very early stages. So the interventions, the therapy begin at very early stages. So there's early intervention. And second thing, there is consistent and regular follow-up. So in most of the cases, we are able to prevent deformities. Since we are able to prevent the deformities, there is no case of there's no point of surgery. Again, if you see in last 2 years, the maximum surgery which I have done in cerebral palsy case is bilateral hip adductor tenotomy for hip displacement, again, which is very common in CP. Now, again, because I know, because most of you might agree that the awareness regarding our specialty is very poor, even among even among our own colleagues. So one way to create awareness regarding our specialty, regarding what we do in CP clinic, is to conduct activities and academic events. So the first symposium, this is in fact the first event conducted by Department of PMR in our institution, was in July 2019, before we started the cerebral palsy clinic, which we conducted a symposium on current trends in the management of cerebral palsy in collaboration with other departments. Then every year we observe National Cerebral Palsy Day. I feel this is one day where you can highlight the work done by CP Clinic to all the higher officials, because they can support you in much better way in future. So this is the first National Cerebral Palsy Day observed in 2020. Because of the COVID pandemic, it was very restricted event. In 2021, we could not observe the National Cerebral Palsy Day because of the COVID pandemic induced lockdown. In 2022, we organized a painting competition for kids with cerebral palsy, and also we have a multidisciplinary symposium on cerebral palsy in collaboration with Department of Orthopedics, Pediatrics, and Anesthesia. In 2023, we had National Cerebral Palsy Day on a bigger scale. I mean, that was a time when I took over the charge as Secretary of IMA Hubballi branch. So I roped in IMA, I roped in a few other NGOs also like GVCT, and we conducted a workshop for caregivers of cerebral palsy. This was called Disha 2, because I had conducted one workshop, similar workshop, way back in 2010, 2011, before joining this institute. So this workshop was named as Disha 2, and this was well appreciated by all the parents who attended the workshop. In 2024, we conducted a simple awareness program for families and kids of children with cerebral palsy. This year, in 2025, again, we conducted an awareness program where I highlighted the work done by CP Clinic in terms of statistics, the research, the interventions, which was well appreciated by the higher officials, which is very much essential for the growth of CP Clinic. Again, we distributed the TLM kits, mobility aids, CP chairs to eligible beneficiaries through Elimco. And then I did a small experiment. I felt that as this is CP Day, it is the function, or it belongs to kids with cerebral palsy. So we should involve them in this function. So I spoke to my team, even they agreed. So we shortlisted on this boy called Adarsh. He's a case of CP spastic diplegia who's coming to us for treatment since last 4 or 5 years. He is very regular. Every month without fail, his father brings him to the clinic for follow-up. With regards to medications, therapy, everything, the compliance is just superb. One of the role models I can say, I have injected him with botulinum toxin for spasticity once, and he's doing very well. So we spoke to him and his parents, even they agreed. So he proposed the vote of thanks for this function, in this function. And this was appreciated, well appreciated by all the higher officials like director, DHO, the dignitaries, other dignitaries present, and all the families, other families of CP children. So I felt this is one way of motivating the child and encouraging him to participate, because I feel even if this child goes to a normal school, this child will be neglected compared to other normal children in school. So this was a good opportunity given to him, and henceforth I've decided in all the other future events with regards to cerebral palsy will involve more kids with cerebral palsy and in bigger roles appropriate to them. Now, coming to research again, which is very important, this one highlights the work done in your department again. Plus, it's a very good way of learning. And thirdly, we all need publications for promotions. So what happened was a couple of years ago, the orthopedics HOD called me and he made me a co-guide for a MS orthopedic student. And that's how this process started. And from there on, almost every year, every second year, I'm a co-guide to a MS orthopedic student, and we give him a topic of dissertation which is appropriate to rehab and orthopedics, and then that way research is being conducted. So from cerebral palsy clinic, we have already published two articles. One is on hips in cerebral palsy, which is a clinical radiological evaluation of hip subluxation in CP. And the other one is clinical study on efficacy of injection botulinum toxin in the management of spasticity in cerebral palsy. These two papers have already been published. If you see the ongoing research, one is assessment of bone health in children with cerebral palsy and its correlation in severity. Here, no PGs are involved. It's being done directly by me in collaboration with Department of Orthopedics and Biochemistry. Then one more study which is ongoing, which is just started, is evaluation of effectiveness of adductor tenotomy in the management of hip displacement in children with cerebral palsy. This study has just been started a couple of months ago, so still a long way to go. The third study is the study of cardiovascular manifestations in patients with cerebral palsy. This is in collaboration with Department of Cardiology. And this study is being taken up by a student who's pursuing his game in cardiology. Now coming to interesting case presentations. First, this is a case of left CP hemiplegia. When he presented to us at the age of 7 years on examination, there's no contracture because more of dynamic spasticity. And we injected him with injection botulinum toxin, 100 units in his gastrosoleus. This is 3 months post Botox. This is 7 months post Botox. He's walking fairly well. He's regularly following up with me once in every 2 to 3 months, and he's doing good even now. So it's almost a year now. We injected him with botulinum toxin, but he's still doing fairly well. There's no recurrence of spasticity. We can call him a golden responder. Again, the second case, this is a case of right CP hemiplegia. You can see him walking. This boy, when he presented to us at the age of 6 years, had already a contracture. In fact, you can see the other foot is also, heel is not touching the ground to compensate, but it's a case of right hemi with a contracture. So in this case, we did simple right guarded tendoachilles lengthening, and usually I apply POP cast and keep the limb with the cast for 6 weeks. The cast is removed after 6 weeks, and then we start weight bearing and post-op rehab, including gait training. So this is just like 6 weeks when he made him walk with the ankle foot orthosis in parallel bars. This is the same case 5 months post-op. This is 1.5 years post-op. He's again under our follow-up. He comes once in 3 to 4 months and is doing fairly well. He wears ankle foot orthosis only in the night times and is doing all the therapeutic exercises. He's not on any medications and is going to school and participating in all his regular activities. This is an interesting case. Again, she's a girl of right CP hemiplegia who presented to us at the age of 8 years. She came to us in early 2020. There's a contracture, and that time we had no access to injection botulinum toxin. So I did the right fraction lengthening of medial hamstrings and the right guarded TL lengthening in this case in 2020. And after the surgery, after 6 weeks, after removal of the cast, there was COVID pandemic. So she could not come for therapy to our institute. She could not be admitted for the therapy also, post-op rehab also. And she suddenly disappeared. She came to me only 2.5 years after post-surgery. And I was pleasantly shocked and surprised to see her and with this gait. She was doing absolutely well with no issues at all. Unfortunately, after this visit, again, she is not turned up for follow-up. So this was the first and last time I've seen her post-surgery. Even though we are trying to get in touch with her and ask her to come for follow-up, unfortunately, that has not happened. Hopefully, we'll be able to follow up again soon in near future. Again, the other case, this is a case of spastic CP triplegia. He presented to us at the age of 12 years. This is how he was walking. He was having a equinus deformity on only one side. So we did bilateral fractional lengthening of medial hamstrings with left guarded tendinoachelis lengthening. And then again, a peculiar thing happened with this boy. After 6 weeks of cast, he was admitted in our institute for removal of the cast and post-op rehab. But immediately once the cast was removed, he suddenly disappeared from the hospital. He just vanished away without informing anybody, including me. And suddenly, then after 2 months, I got a call from the parents that the boy is not walking. Because I feel many times this happens because the parents have a feeling that once you operate or once you give injection botulinum toxin, my child is going to become normal. So I think this we have to educate the parents regarding child's condition and explain them the importance of post-op rehab, which is very, very important. Otherwise, the intervention might fail. So his post-op rehab started quite late. So you can see this is walking with bilateral knee gaiters in a walk, parallel bars, then with walker. So this is post-op 8 months when he is able to walk comfortably without any mobility aids. This is 1 year post-op. This is 3 years post-op. Again, it's not very regular for follow-ups. He comes only when you call him once in 5 to 6 months. But somehow he's doing some therapy at home and he's doing fairly well. This was a case of CP left hemiplegia who presented to me at the age of 18 years. You can see he came with a contracture with a knee deformity and equinus deformity, knee flexion deformity and equinus deformity. Keeping his age in mind and keeping the deformity, he was directly taken up for surgery. And we did the left fractional lengthening of medial hamstrings and guarded tail lengthening. And this is post-op 3 months when he was walking at the AFO. This is 6 months post-op. This is 1 year post-op. This is post-op at 2 years. This is 3 years. It's almost 4 years we've operated him. He regularly comes to follow-up. Every 2 to 3 months without fail, he'll come. Uh, the compliance with medications, with therapy is good. But it is very satisfying seeing him because now he's working in a petrol pump and he's able to earn a living for himself and support his family also. So this, I believe, is complete rehab. There's integration back into the society. So this is a very satisfying picture, and there's a double follow-up now because without fail, every 2 to 3 months he visits me for follow-up. And since this petrol station is near to my home, even I go there as per the need. And whenever I go there, I insist that he needs to attend my car, and that's one way of motivating him and encouraging him to continue his work. Again, as I said, most of the cases which I've shown are CP cases. This was a non-cerebral palsy case, a case with left equinus deformity who presented to me at the age of 10 years. There was no spasticity, no signs of cerebral palsy. Actually, they had presented to me 2 or 3 years earlier. I had advised them surgery because there was a equinus deformity contracture, but the parents had refused surgery. So they turned up again this year, and this time they're willing for surgery. So I did the Z lengthening of left tendinoachilles with Stinler's procedure just few months ago. Uh, I'm sorry. Yeah, this is at 6 weeks. He just started gait training with AFO and parallel bars. This is like 3 months. He's able to walk without any mobility aids. I'm very sure he's coming regularly for follow-up every month, and I'm very sure he'll do much better in coming months. Now, this is different case. I call this CP mimic intentionally because I'm not very sure about the diagnosis. Clinical presentation, if you ask me, it's of spastic diplegia, but both the siblings are involved. And when siblings are involved, it can be a CP mimic or it can be a genetic cause of cerebral palsy. Unfortunately, the patients come from a very low socioeconomic group. They come from Karnataka, Maharashtra border, and they cannot afford investigation. So we did not proceed with further investigations, which are required to, in case of CP mimic or genetic cause of cerebral palsy. But the clinical presentation is that of a CP spastic diplegic, and this is the way he used to ambulate. If you see, he's bearing weight only on the right lower limb. Left, there's a knee flexion deformity and equinus deformity. They are coming to me regularly since last 2 to 3 years. But before coming to me, they had been to Birth Institute, Tirupati, which is again a very well-known institute for management of such cases. And there in Tirupati, only the deformity on the right lower limb was corrected. I'm not sure why only the right lower limb was operated and why not the left, because the discharge card and all other relevant papers have been misplaced with the parents. I was not very keen and hesitant to operate this case, but because the parents are very keen and after me that, sir, they have operated one limb, you correct the other limb, he'll start bearing weight on the other limb also. Uh, as they're very compliant with therapy and all, I operated him just recent this year itself. We did left fractional lengthening of medial hamstrings with left guarded TA lengthening. But managing this case post-op was something unexpected because after 6 weeks of casting, when I removed the cast and gave him a knee gaiter and a A4, I do not know what happened to me, what happened to him. He started howling, crying. He used to not allow any of us to touch his limb. Initially, we tried many things, but he used to just not cooperate in anyone trying to touch his left lower limb, which is operating limb. He used to never allow anybody to remove the knee gaiter also. In fact, couple of times when therapist tried to do some exercises and mobilization, he became violent and he had aggressive behavior. In fact, therapists were not keen on seeing him also. We took an opinion from Department of Psychiatry. Again, they say behavioral issues are there, but they suggested only counseling, no medications are given. Seeing his condition, we discharged him, sent him home. His parents were regularly coming for follow-up, but the moment he used to enter the institute, he used to start crying and howling. And never he has allowed me also to examine his knee or examine his limb. So what we did was we used to teach the parents because the parents said at home is slightly more comfortable. He listens to them. So whatever therapy is required, we used to explain to the parents to do it at home. And just recently when he visited me, for the first time he allowed me to examine his lower limb reluctantly. And the first time he allowed me to take his video. So this is the way he's walking now. In fact, in the video, you can see his younger sibling also, who again has a clinical presentation of spastic diplegia because there are two siblings affected. We think of CP mimic or a genetic cause of cerebral palsy in this case. Now, this is a case of dyskinetic cerebral palsy. He presented to us at the age of 7 years. Um, Unfortunately, like most of us do, I do not have his pre-treatment videos because usually we plan and take a video of the patient only when we are planning an intervention like surgery or injection botulinum toxin. Otherwise, usually we don't take the videos. So it's my fault. I agree. Hence, what I've learned a lesson. Nowadays, any interesting case, any important case, I make videos whether I plan any intervention or no. So this was a case of dyskinetic cerebral palsy. This video is taken just when he started his treatment. We put him on medications type THP. You can see the difficulty he's having in walking. Then apart from medications therapy, we gave him a body weight jacket, which he started doing better. Then his parents got transferred to some other place which is far off, so they cannot come for regular follow-up. So they call me whenever they have any issues. And at times they send me videos like this. So now he's able to walk confidently. This is a video recorded in his village. He's doing fairly well according to parents. He's on all the medications as given and therapy. The parents were really happy and shared this video with me the day when he was able to ride this bicycle on his own with his brother sitting behind. So, what are the lessons to be learned from this model? One, team coordination is key for achieving successful functional outcomes. This is with respect to any other rehab, neuro rehab, or anything. This is very important. Systemic documentation and patient statistics are crucial for tracking progress and research. Collaboration with other departments enhances comprehensive care and supports us in research. CP Day celebrations and other outreach activities help showcase clinic achievements and raise awareness not only among the families but also among the higher officials, which is very, very important for future growth of the service which you are providing. Conclusions. Establishing a dedicated multidisciplinary CP clinic has greatly improved coordination and continuity of care for children with cerebral palsy. Team-based approach ensures better functional outcomes and holistic management. Integration in DIC and other departments enhanced service delivery and resource sharing. Despite challenges, the clinic demonstrates that structured collaboration is feasible and effective in a government setup. Continuous documentation, feedback, and periodic review are essential for sustainability and growth. Parents have appreciated the one-stop system for comprehensive evaluation and management. Thank you.
Thank you, Dr. Anand. Beautiful presentation with your wonderful experiences, showing all your cases. The last but one, your sentence, documentation, and that's is very very important and relevant as far as the treatment is concerned. Whatever work you do, unless you don't keep your records, so whatever you say, nobody is going to believe you. And first thing, second thing is that in your treatment plan also, if you keep record of your cases, and that the best way to make the patient convince is to show the records. So wonderful presentation.
Thank you, sir. Thank you.
uh, yeah, so but most of the cases you have shown us are hemiplegic cases. We are struggling cases with diplegic patient reporting in very late age, say around 14 years or 15 years or 12 years. especially GMFCS 3, 4. So even after doing surgery, limb get correction surgery, still improvements are not that much. And the parents, they have a great hope that since you have put your knife, probably the child is going to run and work. So this is the challenge we are facing.
Yes, sir.
How do you counsel your patients, those who are coming with GMFCS 4 and 5?
Sir, I see. If you ask me, I published in the paper also, sir. The most common type of cerebral palsy which I see in my institute is CP quadriplegia, GMXS 4 and 5. So if you see last 2 years, the most common surgery I've done is only hip adductor tenotomy. After cerebral palsy quadriplegia, the next most common is for me is hemiplegics. Diplegics are very less in our institute. I do not know the reasons why, but they're very quite lesser. So now what, from my small experience, what I do is whenever any case comes, even though I know from day one, from my first consultation, that this child is going to require surgery or botulinum toxin, I never advocate these things to the parents on the first visit. I always talk to them, uh, educate them regarding the child's condition because they have a feeling that the child become completely normal, which is not practically possible. So I take my own time in seeing what the parents want, what the parents are expecting. And then maybe in second or third visit, I talk about surgery or injection botulinum toxin or any other intervention. Because I've seen there are many cases. Of course, when we show cases in a presentation, we only show the good cases. We do not show the bad cases. I have many cases where I failed. And there are many reasons for that. One main reason where my surgery has failed is because of the poor compliance. The patient has not come for follow-up. It might be post-surgery, it might be injection botulinum toxin, because I felt many patients have a notion that once my child undergoes surgery or once my child undergoes injection, the child is going to become normal, completely normal, irrespective whether I go for follow-up or not. So I never advocate all these things in the first visit. I take my own time in studying the patients. Some parents are very keen, some parents are not, some parents are illiterate. So it takes time in counseling them, educating regarding the child's condition. But I'm not in a hurry to operate or to inject, sir. I just take my own time. And I explain the goals very clearly to the parents. Why I'm doing this intervention, what will happen. I'm very clear with my goals and I be realistic, sir. I don't promise them anything.
Yes, fine. But the challenge we are facing is that this get quite up in diplegic and quadriplegic also. This hip adductor tenotomy is just a surgery to prevent hip dislocation or
Yes, sir.
subluxation. Yeah, but the main challenge we are facing, this group of people having a poor hip extensor. So
Yes,
even
sir.
whatever you operate, you can correct the foot and ankle or knee, but hardly any control over the hip extensor, which is anti-gravity muscle to make the child erect. So in spite of all your effort for surgery and distal parts, unless the hip control is not there, everything is going to fail. So that's a major challenge where we mostly depends upon the therapist for the strong control and hip control. So that's the limitations for us. We can't help in that aspect. Whatever surgery are there to augmenting hip extensor, these are all supportive surgeries. If somebody is having grade 3 power of hip extensor, that can be augmented by doing some hamstring transfer to grade adductor tubercle. That's possible. But if somebody is having grade 1 power or the poor, very poor hip extensor power, those cases the results are very bad. And we are fully dependent on the therapist people for this achieving this hip control and trunk control. So in your clinical practice, how do you manage these cases, having hip poor control, hip extensor poor, or sometimes trunk and hip control also poor? So how do you manage these cases?
So it's
Their
difficult, sir. I
cases really
manage.
challenge in your clinical practice, because they have a lot of expectation. They come with the idea that with surgery or with treatment their child is going to work, and when we see them helpless with that, we cannot help you. So that's a really very miserable part from as a doctor, when we look to them that we are helpless, we can't help them for ambulation, which is their bare need. The parents, the first problem, the complaint there is that when my child will going to walk.
Uh, Sir, honestly speaking, that category of patients who come to me are very, very less. In fact, as I said, because thanks to DIC, RBSK, Anganwadi workers, we are getting kids immediately 6 months, 1 year for early identification and management. So, in fact, last 2 or 3 years, I have not got a new follow-up, a new cerebral palsy case beyond 3 or 4 years of age. And this category of patients which you are saying, I agree completely agree, difficult to manage, but last few years I've not come across these cases. So I've not done anything on those cases, sir. So I'm so very sorry to say that I'll not be able to opine on this because my experience is very less in managing those cases.
Okay, let's see any question in the chat box. Uh, is it not advisable to attend a CTB case in a separate clinic that will help in streamlining the management of CTB and like those cases?
Sir, in our institution, we have a separate CTV clinic. Again, it is a weekly clinic run by NGO, MyFoot, uh, by Department of Orthopedics. So usually, yes, some cases are referred to me for soft tissue surgeries and all, but we have a separate CTV clinic, weekly clinic, where all the patients are CTV are managed there. In fact, if a CTV patient comes to me also, I refer it to the CTV clinic. Ponseti method goes on there. It's basically managed by the orthopedic residents, but if required, they refer the patients to me. But we have a separate clinic, sir.
So where can we get weighted jacket?
So body weighting jacket, if the patient is affording, sir, because there is one orthotist in Hubballi in private practice who makes the jacket. I have shown him the design. Some of the patients he charges, I think, around 4 to 5 thousand rupees. So some of the patients who can afford to pay 4 to 5 thousand rupees, they take it from him, sir. But then, because I work in a government setup, many of my patients cannot afford that money. So what a couple of patients have done is I share them the photos of the jacket. Last few of our patients, I don't have the photos right now. They have contacted their own tailor, or they have got it done at their home. Got it done by themselves at their home, sir, because they are not in a position to spend that much of money. So I have some photos and all I show it to the parents and they get it done either themselves or from the tailor if they cannot afford to buy from the orthotist.
Can you highlight some more regarding this? We never use this type of jacket in our setup.
Sir, it's a simple jacket, sir. It has multiple pockets in the front and in the back, and we put sand in it so that the body becomes heavy, the involuntary movements reduce. I have used it, we have used it much before in IAPMR Mumbai, plus I have heard it in some other ICP webinars and all. From there, I got idea of it, sir, and we have been successfully using it, sir.
Is it for the dystonic children or for spastic also?
So it's not for spasticities. It's only for dystonic.
This kind of okay.
It is not for spasticities.
Okay. Any important precautions to be followed or assessed in children before giving buttocks?
Sir, I usually, I don't know, but I usually give injection botulinum toxin in the under sedation, sir, because I give it by blind technique. I don't use ultrasound machine. So initially, 1 or 2 cases, when I tried without anesthesia, without sedation, the child starts crying, starts shaking his limb around. So there's always a chance that you might not inject into the point where you exactly want to inject. So from the days when I was a PG, I have learned that the best way to give injection botulinum toxin to a pediatric patient is under sedation. So you are comfortable, the child is comfortable. So I follow the same trend now. I just make sure it's dynamic spasticity. There is no element of contracture because the patients are paying for an injection and it is an expensive injection. Just make sure you choose the right muscle, the right patient and the right dose. And then I give it under sedation to all the pediatric cases. Adult cases, I'm giving it without sedation. And I mean, the most important thing to follow is choosing the right patient, the right muscle, and the right dose. Giving technique is very simple. Unless until you choose the right muscle, the right patient, and the right dose, it will not be a success.
Do you have any experience of using phenol for CP?
Sir, phenol, I've used it when I was working as a PG, sir, in Mumbai. Unfortunately, here we don't get phenol. I've spoken to Department of Pharmacology a couple of times. There's no support from Department of Pharmacology, or I could not get freshly prepared phenol in Hubli. I had to get it from Mumbai. And again, that's the reason why logistics didn't work out. So I have no experience of using injection phenol in this institute, but I've used it in Mumbai, sir, when I was a PG and when I was working as a senior resident.
Any experience of using tone inhibiting cast for your patients?
No, sir. I mean, that unfortunately I wish to, but because of resource limitations, the tone limiting casks are not available in Hubli, sir. None of the Mahavir Artificial Limb Center or none of the orthotists which we have in private are making tone inhibiting casks.
Okay, there is no more questions in the chat box. Then we can uh, sum up the session.
Sir, can I ask a question?
Yes, yes, please, please.
Hi, I'm Dr. Abhinav.
Yeah.
Sir, your experience about this community-based rehabilitation for CP and institution-based rehabilitation.
I'm
Because
sorry, institution based and
community-based.
okay.
The reason being because when one of the biggest CP clinic in Bihar region is in IGIMS where I was working. Because
Okay.
many a time in the CP clinic in IGIMS, I used to find it difficult to convince the patient to stay in Patna because a mother is there, another sibling she has to take care, and no one is there to support. So they always prefer to go to community-based rehabilitation. So your experience and your talk on that,
See, I
take on that.
completely agree. Convincing the patients to come regularly for therapy, regularly for follow-up is difficult. Some patients do not have the money to come because my patients come at times of far off places. So what we do now is we try when the patient comes to us for the first time, we try to explain that initially maybe you have to come a few times till the evaluation is over, till we do a goal setting, and then we start on the management. And then we call the patient probably once in a month or once in 2 months if the patient is doing well. That's one way patients compliance has improved. Second way, now our state government has started therapy units in many PHCs. So what we do is we coordinate with the physiotherapists there working in the PHCs. So these patients go for therapy every week, twice a week to the respective PHCs. And they come to us for follow-up maybe once in 2 months or once in 3 months. So there are many of our CP children who are following this model. And the results are fairly good.
Okay,
Dr.
thank you, sir.
Abhinav, do you have a experience of having this, managing this CP children at a community level as you're talking up, you have a center at Bihar?
Uh, Sir, what we used to do is we used to teach the patient all the therapy and all. We have an occupation therapist who used to do that. And what we used to do is we used to ask the patient to send a video, WhatsApp video. We have a we have a one mobile number which we used to share with the patient, and we used to follow up on the mobile because if the patient is coming at some point of time, it is difficult for them to turn up every month. So they used to turn up after 3 months or 4 months. In between, they will leave this antispastic medication, whatever we are prescribing. So that was a challenge. So if they are following up on WhatsApp, we have a continuous communication with them, and so it is easier for it. We used to get a good compliance. If someone is from very low socioeconomic strata and parents are not available on WhatsApp, it was really a difficult and a challenging thing for us. And another thing which sir was saying that since we used to see he is seeing patients in around 5 years of age. That is really early rehabilitation. If we start it, most of them, these deformities can be prevented. Because most of the patients who turn up to us with deformity are at the age of 9 years, 10 years. And at that point of time, whenever you used to ask, have you ever been rehabilitated? The answer is no. So I think early rehabilitation definitely has a big role to play.
Yes, that's also very important thing, that if the parents are bit cautious about that, if the rehab can be started in early stages before the fixed deformity is established, probably those cases can be managed well. Of course, the CP is such a thing that it is not about the contractures and deformity is a major role. There are lot many things are there which are beyond our control, like selective motor control and associated with the involuntary movements. These are the challenges where whatever procedure will do, you cannot assure the patient that he is going to well. So certain things are beyond our scope or beyond our hand. We can't help them, but still, as a physiatrist, as a surgeon, we should try to our best level to prevent deformity, to make them stand with orthosis or by therapy means. One more question still. What's your opinion regarding phenol in CP? I think we have already discussed that part. Right. So, Sandeep was asking, I think we have discussed partner, phenol you are not using, but phenol people using for the adductor obturator in this block, but hardly phenol is used for other purposes nowadays because availability of this botulinum toxin even under Ayushman Bharat. So, and many national institutes also, this botox are available free of cost. So hardly phenol is used in any center for especially other areas except adductors. And we have, if you have also scope of some surgical skills, you can better way can be managed with anterior division obturator neurectomy and adductor tenotomy. So phenol is now not much used in CP practice, I suppose. Is it okay, Dr. Anand?
Yes, sir. I very few centers are doing it, sir. I think one center which is using phenol very commonly, which I am aware of, is CMC Vellore. But I do not know which category of patients are using it. But one center which is using phenol very commonly is CMC Vellore.
Okay. Fine. Thank you very much. No more questions in the chat box. I thank Dr. Burma for giving his consent for this beautiful presentation and sharing the experience. And I must thank all the participants joining with us for this monthly academic webinar. And thank you, the PR team of our IAPMR for giving us this opportunity, organizing this webinar every month. And I must thank my colleagues of my state association and my departments for encouraging, for arranging such webinar. Thank you all. Thank you all for joining with us. Good
Thank you, sir.
night.
Thank you all. Thank you. Thank you.
Thank you, sir.